Welcome to Pediatric Case Review. Today, we present a comprehensive case-based review of Pompe disease, also known as Glycogen Storage Disease Type 2, prepared for general pediatricians. Pompe disease is a lysosomal storage disorder, where early recognition and treatment can dramatically change outcomes. Across this lecture, we will work through 16 clinical cases, covering the infantile and late-onset presentations, the characteristic examination findings, the underlying pathophysiology and genetics, the diagnostic workup and newborn screening, treatment with enzyme replacement therapy, and long-term complications and monitoring. Let us begin. Question 1. A 4-month-old male presents with poor feeding, decreased activity, and breathing difficulty for 3 weeks. Chest X-ray shows massive cardiomegaly. Echocardiography reveals severe hypertrophic cardiomyopathy. The serum creatinine kinase is 850 units per liter. What is the most likely diagnosis? Option A, dilated cardiomyopathy due to viral myocarditis. Option B, glycogen storage disease type 3, Corey disease. Option C, glycogen storage disease type 2, infantile onset Pompe disease. Option D, Danon disease. The correct answer is option C, infantile onset Pompe disease. The cardinal triad of classic infantile Pompe disease is hypertrophic cardiomyopathy, profound hypotonia, and respiratory failure. The key clue is severe cardiac hypertrophy in a young infant combined with weakness and an elevated creatine kinase. In infantile onset disease, the acid alpha-glucosidase enzyme activity is severely deficient, typically less than 1% of normal. Distinguish this from Danon disease, which is X-linked and presents in older males, and from glycogen storage disease type 3, which features hypoglycemia and hepatomegaly, rather than this degree of cardiac hypertrophy. Question 2. A 14-year-old girl presents with progressive proximal muscle weakness over 2 years, difficulty climbing stairs, and frequent falls. She has loud nocturnal snoring and daytime somnolence. The serum creatinine kinase is 420 units per liter. Forced vital capacity is 68% of predicted. There is no hepatomegaly and no hypoglycemia. Which investigation should be ordered first? Option A, dried blood spot acid alpha-glucosidase enzyme activity assay. Option B, muscle biopsy with periodic acid shift staining. Option C, echocardiogram. Option D, serum lactate and pyruvate. The correct answer is option A, the dried blood spot acid alpha-glucosidase enzyme activity assay. This is the recommended first-line screening test. It is minimally invasive, requiring only a simple heel prick or finger prick blood sample. It detects all forms of Pompe disease, both the infantile and the late-onset presentations. Importantly, every screen-positive result requires confirmatory testing. Confirmation is done with leukocyte or fibroblast acid alpha-glucosidase activity together with acid alpha-glucosidase gene sequencing, in line with the American College of Medical Genetics 2023 guidance. A muscle biopsy is more invasive and is no longer the first step when a simple enzyme assay is available. Question 3. A 3-week-old infant presents with profound hypotonia, poor suckling, biventricular hypertrophy with a left ventricular wall thickness z-score of +6 and a serum creatine kinase of 1,200 units per liter. Which electrocardiogram finding is most characteristic of classic infantile Pompe disease? Option A, prolonged QT interval. Option B, right bundle branch block. Option C, street segment elevation. Option D, short PR interval with high voltage QRS complexes. The correct answer is option D, a short PR interval with high voltage giant QRS complexes. This pattern is considered pathognomonic in classic infantile onset Pompe disease. The mechanism is glycogen accumulation within the myocardium, which produces marked biventricular hypertrophy. The glycogen-laden hypertrophied ventricular muscle accelerates atrioventricular conduction, which shortens the PR interval, while the massive muscle bulk generates the very high-voltage QRS complexes. So, glycogen accumulation in the heart leads to biventricular hypertrophy, and that hypertrophy produces this characteristic electrocardiogram signature. Question 4. A 5-month-old infant has confirmed infantile onset Pompe disease. Which physical examination findings are most expected? Option A, frog leg posture, head lag, macroglossia, and absent deep tendon reflexes. Option B, opisthotonos with hyperreflexia and clonus. Option C, asymmetric limb weakness with preserved cranial nerve function. Option D, spastic paraparesis with extensor plantar responses. The correct answer is option A. The classic infantile examination shows a lower motor neuron pattern of weakness. Frog leg posture means the hips lie abducted and externally rotated at rest because of profound hypotonia. Profound head lag reflects an almost complete absence of neck muscle tone when the infant is pulled to sit. Macroglossia, an enlarged tongue, results from glycogen accumulation in the tongue muscle. Deep tendon reflexes are markedly reduced or absent. The key concept is that a lower motor neuron pattern of weakness combined with cardiomegaly points to Pompe disease, whereas spasticity, hyperreflexia, or extensor plantar responses are upper motor neuron signs and argue against it. Question 5. A 10-year-old boy with late-onset Pompe disease is being evaluated in clinic. Which physical findings would you expect on examination? Option A, hepatosplenomegaly and icterus. Option B, peripheral neuropathy with absent ankle jerks. Option C, proximal limb girdle weakness, lumbar hyperlordosis, and scapular winging. Option D, facial diplegia and ptosis. The correct answer is option C. Late-onset Pompe disease produces a proximal limb girdle pattern of weakness, with the hip flexors typically more affected than the shoulder girdle. Lumbar hyperlordosis appears as an exaggerated lumbar curve when the child stands, a compensation for weak hip and trunk muscles. Scapular winging results from weakness of the serratus anterior and trapezius. A positive Gowers sign is also seen, where the child uses the arms to climb up the legs when rising from the floor. A crucial distinction from infantile disease and other glycogen storage disorders is that there is no hepatomegaly, no peripheral neuropathy, and no cardiomyopathy. Question 6. Which statement best describes the primary enzymatic defect and cellular consequence of Pompe disease? Option A, deficiency of muscle phosphorylase, leading to failure of cytoplasmic glycogenolysis. Option B, deficiency of debranching enzyme, leading to limit dextrin accumulation. Option C, deficiency of glucose 6-phosphatase, leading to hypoglycemia and hepatomegaly. Option D, deficiency of acid alpha-glucosidase, leading to lysosomal glycogen accumulation in all tissues. The correct answer is option D, deficiency of acid alpha-glucosidase. Acid alpha-glucosidase is the sole lysosomal enzyme responsible for breaking down glycogen inside the lysosome. When it is deficient, glycogen progressively accumulates within lysosomes, especially in cardiac and skeletal muscle. The swollen lysosomes eventually rupture, causing cell dysfunction in cardiac, skeletal, and smooth muscle, and ultimately organ failure, including heart failure, respiratory failure, and motor loss. A key distinguishing point is that cytoplasmic glycogenolysis, the phosphorylase pathway, remains intact in Pompe disease, which separates it from the other glycogen storage disorders. Residual enzyme activity determines severity. Less than 1% produces classic infantile disease, while 1 to 10% produces the late-onset form. Question 7. Which statement about Pompe disease genetics is correct? Option A, Pompe disease is X-linked recessive with male predominance. Option B, Pompe disease is autosomal recessive, and the most common variant in Caucasians with late-onset disease is the intron 1 splicing variant, C.-32-13T to G. Option C, de novo mutations account for more than 50% of cases. Option D, carrier parents each have a 50% risk per pregnancy of an affected child. The correct answer is option B. Pompe disease is inherited in an autosomal recessive manner. When both parents are carriers, each pregnancy carries a 25% risk of an affected child, not 50%, which is why option D is incorrect. The most common variant in Caucasian patients with late-onset disease is the intron 1 splicing variant, C.-32-13T to G. This variant leaves roughly 10% residual acid alpha-glucosidase activity, which produces a milder late-onset phenotype. In contrast, infantile onset disease is typically caused by null mutations, such as nonsense or frameshift mutations, which leave less than 1% residual activity and cause the severe infantile phenotype. The key rule is that residual enzyme activity determines disease severity. Question 8. A 2-month-old with hypotonia and cardiomegaly is suspected to have infantile onset Pompe disease. Which combination provides the definitive diagnosis? Option A, muscle biopsy with periodic acid Schiff stain plus serum creatinine kinase. Option B, echocardiogram plus brain magnetic resonance imaging. Option C, dried blood spot acid alpha-glucosidase enzyme activity plus acid alpha-glucosidase gene sequencing. Option D, urine oligosaccharides plus serum lactate. The correct answer is option C. Definitive diagnosis requires two findings together. First, deficient acid alpha-glucosidase enzyme activity, confirmed in leukocytes or fibroblasts. The dried blood spot screen leads on to this confirmatory tissue assay. Second, the identification of two pathogenic variants in the acid alpha-glucosidase gene by gene sequencing using either Sanger sequencing or a next-generation sequencing panel. Gene sequencing is essential because it helps avoid false positives caused by pseudodeficiency alleles. According to the American College of Medical Genetics 2023 guidance, both findings are required, and neither the enzyme result nor the genetic result alone is sufficient for a definitive diagnosis. Question 9. Which statement about newborn screening for Pompe disease is most accurate? Option A, dried blood spot acid alpha-glucosidase enzyme activity can detect both infantile and late-onset forms, and confirmatory testing is required for all screen positives. Option B, newborn screening is only useful for detecting the classic infantile form. Option C, a normal newborn screen completely excludes Pompe disease. Option D, newborn screening uses urinary glucose tetrasaccharide as the primary biomarker. The correct answer is option A. Dried blood spot acid alpha-glucosidase enzyme activity detects all forms of Pompe disease, both infantile onset and late onset, which makes option B incorrect. Every screen-positive result requires confirmatory testing, in particular to exclude pseudodeficiency, where the pseudodeficiency allele lowers measured enzyme activity without causing actual disease. Molecular testing sorts this out. A normal screen does not absolutely exclude every case, so option C overstates the test. The great value of newborn screening is that it allows enzyme replacement therapy to be started before symptoms appear, and pre-symptomatic treatment leads to dramatically better outcomes. Question 10. A 7-year-old girl with confirmed late-onset Pompe disease is on routine follow-up. Which tool is most useful for tracking respiratory muscle weakness progression? Option A, serial echocardiograms every 6 months. Option B, annual nerve conduction studies and electromyography. Option C, brain magnetic resonance imaging with gadolinium every 2 years. Option D, spirometry, measuring forced vital capacity % predicted, both upright and supine, every 6 months. The correct answer is option D, spirometry measuring forced vital capacity, performed both upright and supine, every 6 months. A drop in forced vital capacity of more than 10% when moving from upright to supine indicates diaphragmatic weakness, because a weak diaphragm cannot work against the abdominal contents when the patient lies flat. When the forced vital capacity falls below 50% of predicted, non-invasive ventilation should be initiated. Cardiac echocardiography is mainly for monitoring infantile onset disease, not the late onset form. Forced vital capacity % is the single most important prognostic indicator in late-onset Pompe disease. Question 11. A 3-month-old infant presents with hypotonia, hypertrophic cardiomyopathy, fasting hypoglycemia, and hepatomegaly with elevated transaminases. The acid alpha-glucosidase enzyme activity is normal. What is the most likely diagnosis? Option A, infantile onset Pompe disease. Option B, Glycogen Storage Disease Type 5, myocardial disease. Option C, Glycogen Storage Disease Type 3, Corey disease. Option D, Glycogen Storage Disease Type 9. The correct answer is option C, Glycogen Storage Disease Type 3, also called Corey disease. The single most important clue is that the acid alpha-glucosidase enzyme activity is normal, which rules out Pompe disease. 2 further features point to Type 3. Fasting hypoglycemia, which is present in Corey disease but not in Pompe disease, and prominent hepatomegaly with elevated transaminases. Type 3 is caused by a mutation in the AGL gene, leading to deficiency of the debranching enzyme. So, although this infant has hypotonia and cardiomyopathy that could suggest Pompe disease, the normal enzyme level plus hypoglycemia and liver involvement identify Corey disease. Question 12. A floppy infant at 2 months is evaluated. Nerve conduction studies are normal. Electromyography is myopathic. The dried blood spot acid alpha-glucosidase activity is severely reduced. Before the enzyme results were available, which conditions should have been in the differential diagnosis? Option A, spinal muscular atrophy type 1, congenital myopathy, and neonatal myasthenia gravis. Option B, cerebral palsy, Down syndrome, and benign neonatal hypotonia. Option C, Duchenne muscular dystrophy, Becker muscular dystrophy, and limb-girdle muscular dystrophy. Option D, Krabbe disease, Gaucher type 2, and GM1 gangliosidosis. The correct answer is option A. For a floppy infant with this picture, the differential includes spinal muscular atrophy type 1, congenital myopathy, and neonatal myasthenia gravis. Spinal muscular atrophy type 1 shows a normal creatine kinase, fasciculations, and SMN1 deletion, and importantly, no hypertrophic cardiomyopathy. Congenital myopathies are diagnosed by muscle biopsy and characteristically lack cardiomegaly. Neonatal myasthenia gravis is caused by transplacental maternal antibodies, is self-limiting, and improves with a cholinesterase inhibitor test. What distinguishes Pompe disease from all of these is the combination of cardiomegaly and elevated creatine kinase and severely reduced acid alpha-glucosidase activity. Question 13. A 3-month-old male is newly diagnosed with classic infantile onset Pompe disease through newborn screening. Echocardiography confirms severe biventricular hypertrophic cardiomyopathy. The acid alpha-glucosidase enzyme activity is less than 1%. He is currently pre-symptomatic. What is the most important initial treatment decision? Option A, initiate high-protein dietary therapy immediately. Option B, start prednisolone immunosuppression to reduce anti-enzyme antibodies. Option C, perform cardiac transplantation as soon as possible. Option B, initiate enzyme replacement therapy with L-glucosidase alpha at the earliest opportunity, ideally within the first weeks of life. The correct answer is option D. The most important initial decision is to start enzyme replacement therapy with L-glucosidase alpha as early as possible. The standard regimen is 20 milligrams per kilogram given intravenously every 2 weeks. Starting early, ideally within the first weeks of life, is critical, and pre-symptomatic initiation through newborn screening produces the best outcomes. Early enzyme replacement therapy can dramatically reverse the hypertrophic cardiomyopathy. Untreated infantile onset Pompe disease is typically fatal before the age of 2 years. The central message is that earlier enzyme replacement therapy means better cardiac and survival outcomes. Question 14. An infant with infantile onset Pompe disease on L-glucosidase alpha develops high sustained antibody titers along with declining motor function. What is the best next management step? Option A, double the enzyme replacement therapy dose to overcome the antibodies. Option B, immune tolerance induction with rituximab, methotrexate, and intravenous immunoglobulin. Option C, discontinue enzyme replacement therapy and switch to dietary therapy. Option D, allogeneic hemopoietic stem cell transplantation. The correct answer is option B, immune tolerance induction. High sustained antibody titers against the replacement enzyme can neutralize the therapy and lead to declining motor function. Immune tolerance induction uses a combination of rituximab, which depletes B cells, methotrexate, which suppresses T cells, and intravenous immunoglobulin, which provides immune modulation. Ideally, this regimen is started before or at the time of the first enzyme replacement infusion, and it is especially important in cross-reactive immunologic material negative patients who make no native enzyme and are at highest risk of forming these antibodies. For this reason, the cross-reactive immunologic material status must be determined before starting enzyme replacement therapy. Question 15. What is the main advantage of L-glucosidase alpha, the next generation enzyme, over the first generation L-glucosidase alpha? Option A, it is administered orally with no intravenous infusion required. Option B, it crosses the blood-brain barrier, preventing central nervous system glycogen accumulation. Option C, it has higher mannose 6-phosphate content, giving superior lysosomal targeting. Option D, it eliminates the need for immune tolerance induction in cross-reactive immunologic material negative patients. The correct answer is option C. The main advantage of L-glucosidase alpha is its higher mannose 6-phosphate content, approximately 7 times more than the first-generation enzyme. Mannose 6-phosphate is the tag that allows the enzyme to bind the cation-independent mannose 6-phosphate receptor on muscle cells. More of this tag means superior receptor binding, enhanced cellular uptake, and greater clearance of glycogen from the lysosome. L-glucosidase alpha was approved by the United States Food and Drug Administration in 2021. In the COMET trial, it showed better motor and ventilator-free survival outcomes compared with the first-generation enzyme replacement therapy. It still requires intravenous infusion and does not cross the blood-brain barrier, so options A and B are incorrect. Question 16. A 6-year-old girl with infantile onset Pompe disease started on enzyme replacement therapy at 3 months of age through newborn screening, develops new hearing loss on annual audiology screening. What is the most likely explanation? Option A, sensory neural hearing loss from glycogen accumulation in cochlear structures, an enzyme replacement refractory complication. Option B, otitis media with effusion from chronic respiratory illness. Option C, aminoglycoside ototoxicity from antibiotic treatment. Option D, syndromic hearing loss unrelated to Pompe disease. The correct answer is option A. The hearing loss is sensory neural, and it results from glycogen accumulation in the cochlear hair cells and the spiral ganglion neurons. These cochlear structures are poorly penetrated by enzyme replacement therapy, so this is considered an enzyme replacement refractory complication. Because the therapy does not reach these structures well, the sensory neural hearing loss tends to worsen progressively with age, which is why annual audiology assessment is mandatory for all Pompe disease patients. Other complications that are similarly refractory to enzyme replacement therapy because of poor tissue penetration include white matter changes in the brain, scoliosis, and speech delay. This reflects an important concept. Enzyme replacement therapy transforms survival, but it does not protect every tissue equally. Before we close, I want to invite you to join our community, Pediatric Case Review, on Patreon. Inside the community, all of our videos are arranged systematically by body system, so you can access every lecture in one place and study in a structured way. Every presentation used in the videos is also available as downloadable images, so you can read through them and practice all of the questions offline at your own pace. It is a simple way to support the channel and to learn more effectively. If you would like details on how to subscribe, just leave a comment below this post, and we will message you directly. Let us bring it all together with the key takeaways every pediatrician should remember about Pompe disease. 1. The underlying defect is acid alpha-glucosidase deficiency, causing lysosomal glycogen accumulation in all tissues, especially cardiac and skeletal muscle. 2. Infantile onset disease shows the classic triad of hypertrophic cardiomyopathy, profound hypotonia, and respiratory failure, and is fatal before age 2 without enzyme replacement therapy. 3. Late-onset disease is later and milder, with limb girdle weakness and respiratory insufficiency, but no cardiomyopathy and no hypoglycemia. 4. Diagnosis takes 2 steps: dried blood spot enzyme activity plus gene sequencing, both required. 5. Treat early because enzyme replacement therapy saves lives, with avaloglucosidase alpha preferred and newborn screening enabling a pre-symptomatic start. 6. Monitor for life, with forced vital capacity every 6 months and annual audiology, since sensory neural hearing loss is refractory to therapy and worsens with age. Thank you for joining this Pediatric Case Review lecture on Pompe disease. We hope this case-based review strengthens your clinical approach to this condition. If you found this helpful, please follow the channel for more case-based pediatric lectures. And if you have any questions, leave them in the comments and we will be glad to respond. Remember, this content is intended for educational purposes only and does not constitute direct medical advice. Clinical decisions should always be based on current guidelines and specialist input. We will see you in the next lecture.